course, as with every examination, we will follow the format of starting with YP. And then we will examine some general characteristics such as appearance, and those would be the same that would have been detailed before in global assessment. General observation, which is an ability to ambulate, posture, stance, at rest, etc. Extra-articular or peri-articular manifestations of musculoskeletal disorder, which will be as follows. First, we will examine specific areas. This is carried out under the headings look, feel, and feel will be ideally touch and palpate. Move will be active and passive range of movement, and function. So I repeat, look, which is like inspection, feel, move, and function. Now the function and movement are dependent on each other. For example, loss of range of movement at a joint will result in some impaired function. General observations will include looking at the patient. We'll have to ask them to disrobe. Ideally, they will be in shorts. They'll be standing in the erect position. We observe from the front, from the sides, from the back. And we'll be looking at things such as stance. Don't forget that normal spinal curvature, cervical and lumbar lordosis and thoracic kyphosis, abnormal curvatures such as scoliosis or exaggerated kyphosis, and spinal alignment, level of iliac crest, limb length, and contractures and deformities and angulations. Of course, we will speak about the gait, so in that we usually ask the patient to walk a bit. So the patient will take a few steps away from the examiner and then turn around and walk towards the examiner. And we, of course, will be taking note of all the pathological gaits, and that will have already been demonstrated in the global assessment video. Other things we will be looking at generally are symmetry and smoothness of movement, length of stride, ability to turn smoothly, the stability of walking, extra-articular manifestations including things such as rashes, and we will be also checking for nodules in the joints, etc. Then we'll be checking the eyes for signs of inflammation, and then we'll be checking for mucocutaneous manifestations in the mucous membranes. General things include chest expansions, constitutional symptoms, lungs and neuropathies, and heart murmurs and effusions are all included in these extra-articular manifestations. We will first begin the examination with the axial skeleton. The temporomandibular joint, both these joints are assessed simultaneously. Movement will be incorporated into the look and feel for this joint. So we'll start with the look. We look for deformity at rest. Then we ask the patient to open his or her mouth as wide as possible, then close. Then we ask the patient to move his jaw from side to side. Then we ask the patient to move his or her jaw forward and backwards. We feel by placing a finger over the temporomandibular joint while the patient repeats the above movements. So again, open, close, side to side, back, forward. We'll then proceed with the spine. For this examination, the patient stands with both feet together. You'll look at the entire spine from the base of the skull to the sacrum, from posteriorly and also from laterally. We'll be looking for things such as normal curvatures. Remember, cervical and lumbar are concave posteriorly and thoracic is convex posteriorly. Look also for scoliosis, kyphosis, and for symmetry. Remember, asymmetry may be due to muscle wasting or spinal curvatures. We'll then proceed to feel. We'll be feeling the spinous processes, which should be midline, forming a straight line. Remember that at C7, that should be the most prominent. We'll feel for warmth also. And we'll check for tenderness over the paraspinal muscles, the vertebrae, and the sacroiliac joint. We will then proceed with the move technique, in which case we will ask the patient in the spine to carry out the active range of motion. Now, that is a patient's moving the joint for him or herself. Starting with the cervical spine, ask the patient to nod. This is testing the atlanto-occipital joints. Then ask the patient to turn their head from side to side, as if indicating disapproval. And this is testing the atlanto-axial joints. The other movements are the cervical intervertebral disc. So flexion, we ask the patient to touch their chin to their chest. Extension, we ask the patient to look up at the ceiling. Lateral flexion, we ask the patient to bring their right ear to the right shoulder without moving the actual shoulder. Then we repeat it with the left ear and left shoulder. Please note that while the patient is doing these movements, you will palpate the spine for crepitus. Rotation, we'll ask the patient to look over their right shoulder and then repeat it with their left shoulder. Please note that while the patient is doing these movements, you will palpate the spine for crepitus. Now there's very little movement in the thoracic spine, so we will then proceed with the lumbar spine. With the patient standing straight, the examiner places 2 fingers over the lumbar spine. We then ask the patient to bend forward, which is flexion, to touch his toes, and then to bend backwards as far as he can or she can. And your 2 fingers should separate during flexion and come together during extension. We then proceed with lateral flexion. With the patient standing straight, ask the patient to bend sideways by walking their fingers down the outside of the leg. First right, and then left. We will then proceed with rotation. With the patient sitting on the edge of the couch or bed, which fixes the pelvis, the forearms are crossed in front of him or her. And then we ask the patient to rotate the trunk by turning the trunk to the right, looking behind them as far posteriorly as possible. Then the same is repeated for the left. The examiner places his hands on the patient's shoulder to help guide the trunk. Then proceed with a special test for the spine. We will check for any sciatic nerve root irritation or entrapment. And this is done by using 2 tests. The first is the Lessegs or straight leg raise test. With the patient lying supine, we hold each leg by the ankle and raise each leg straight, 1 leg at a time, passively to about 60 degrees, between 30 and 70. And the patient with sciatic nerve root irritation will experience pain in the lumbar spine or down the lower limb or both. The second test is called a bowstrings maneuver. In a patient experiencing pain at 60 degrees, but for our lab, we will do this in all patients either way. From the position of pain, we lower the leg until the pain is just relieved. And then we will dorsiflex the foot. Recurrence of the pain above confirms the sciatic nerve root irritation or entrapment. We'll then proceed with the sacroiliac joint for sacroiliitis. The test for this joint is called a sacroiliac joint stress maneuver. We will ask the patient to lie supine very close to the edge of the bed or couch, and we'll stand close to the patient at the edge to prevent the patient from falling. We'll then ask the patient to fully flex the knee and hip of the lower limb further away from the edge. To hold the knee tightly against the abdominal wall with both hands clasping the flexed knee. We will then slide the other leg, thigh, and part of the buttocks off the couch and push firmly down on the knee of that limb. That's essentially hyperextension at the hip. And then the movement now occurs at the sacroiliac joint and not at the hip joint. All right? We'll then repeat the same on for the other side. The examiner will come over to the other side of the bed. And then the same test will be done. Good. This concludes the test for the axial skeleton. We will now proceed with the appendicular skeleton. The appendicular skeleton, as we said before, is divided into upper and lower limbs. We will start with the upper limb. We will do the examination of the upper limb in a cephalocortical direction, starting with the shoulder joint. This includes the scapula, the acromion, the acromioclavicular joint, the clavicular and sternoclavicular joints. So you will look at the appearance, checking for symmetry with the opposite joints, observe for posture, muscle wasting, scars, example, previous arthroscopy. and redness, which an example of that can be caused by septic arthritis. You will then feel. We'll first feel for the warmth of the joints. Then we will be checking body landmarks. So we palpate for swellings and tenderness in the bony landmarks, such as the sternoclavicular joints, the clavicle, the acromioclavicular joints, and around the scapula. Also for tenderness over the long head of the biceps, the tip of the shoulder, the subacromial bursa, and the joint line. We'll also palpate over the anterior and posterior aspects of the joint for fullness and effusion, and we'll check the muscle bulk of the deltoid, swellings and masses. The move part of this joint examination, during the movement of any joint, we always look at the patient's facial expression for evidence of pain being felt. So we'll first test the active range of motion at the shoulder. We'll first start with flexion, have the patient stand with the upper limbs in the anatomic position, and to bring both arms and forearms upwards toward the ceiling until the upper extremity is parallel to the floor. Then we will do extension. The patient stands with the upper limb by his side in mid-prone position. Ask the patient to rotate the forearm with the palm facing downwards and then move straight upper extremity as far back as possible. For abduction, stand behind the patient during this movement to assess movement of the scapula. The patient stands with extended upper limbs by the sides. The upper limbs are moved away from the body with palms facing down. And then adduction, return of the abducted upper extremity to its anatomical position is in fact adduction. Then we continue with internal medial or external lateral rotation. We ask the patient to hold his or her hands by the side with forearms flexed at 90 degrees and supinated. And the elbows are held against the side of the trunk, and the patient is then rotate the shoulders by pointing the forearms outwards. This is external rotation. We then reverse the maneuver for internal rotation. We then ask the patient to put his hands behind his head. This tests shoulder abduction and external rotation and elbow flexion. And then we ask the patient to place their hands behind their backs, just above the buttocks. This tests shoulder abduction and internal rotation and elbow flexion extension. Ask the patient to walk up their back with the hand and assess how far they can reach from the lumbar to lower thoracic or mid-thoracic region. Passive range of movement is done by you, the examiner, putting the joint or limb through all the movements above and uses opportunity to palpate for crepitus over the joint. The same will be then repeated for the other arm. We will then continue now with the joint of the elbow, where we will first look for the carrying angle. We also look for muscle wasting. We also look for symmetry with the other elbow. We look for scars, rashes, nodules, and swellings. We then proceed to feel for warmth, tenderness, nodules and swellings, and we'll test for the latter by placing the elbow in a 90 degrees of flexion. Support the elbow with one hand. With the thumb of the same hand, we will palpate the head of the radius and the posterior lateral joint line. We'll palpate the posterior medial joint line with the fingers, and basically a fluctuant swelling between the lateral epicondyle and the olecranon often indicates synovitis. We'll then proceed with the movements at the elbows. We'll test for both active and passive movements. Remember to feel for crepitus during the movements. So first we will do flexion extension. Place the upper limb in the anatomical position, bend the elbow towards the trunk, bring in the hand towards the trunk and trying to rest the fingers on the respective shoulders. That's flexion. Now extension is to return to the position where the upper limb is straight. This is extension. We'll then continue with pronation and supination. Ask the patient to hold the arms close to the side of the trunk with the elbows at 90 degrees of flexion. Have the patient rotate the forearms until the palms face down. This is pronation. Then have the patient rotate the forearm until the palms face up. This is supination. We'll then continue with a special test for lateral epicondylitis. The first test is called the Cozen's test. We place the elbow to be tested in 90 degrees of flexion. The thumb of one hand of the examiner is placed over the lateral epicondyle of the flexed elbow. We'll then have the patient pronate the forearm, make a fist, and radially deviate and extend or dorsiflex the wrist. The other hand of the examiner, of course, applies pressure or resistance to the patient's proximal hand during the active extension in an attempt to palmar flex the wrist. You'll be looking for pain. Then we will continue with the medial epicondylitis examination, which is called examination for medial epicondylitis. You will palpate over the medial epicondyle. Ask the patient to flex his wrist while the examiner is providing resistance with one hand, resulting in a pain is a positive for this test. And we ask the patient to pronate his forearm while the examiner is providing resistance with one hand, resulting in pain. We also tap over the ulnar nerve at the elbow, and a shooting pain down the distribution of the ulnar nerve is a positive Tinel sign and evidence of an ulnar neuropathy. The examination of the hands and the wrists will continue. We always compare both sides, one with the next. We'll first start with inspection and palpation of the hands, and wrists will be done together. Movement of the digits will be treated separately from that of the wrist. So look, with the hands resting on the pillow, table, or on the patient's thigh. First, with the patient's hands palms down, observe the wrists and hands and fingers for the following. Posture of the hand and wrist. Swellings or nodules. Remember, bony swellings in the area of the interphalangeal joints is more likely to be related to degenerative arthritis, Heberdine's DIPs, and Bouchard's PIP notes. That of the metacarpophalangeal joint is more likely to be related to rheumatoid arthritis. Deformity and deviation. We look for the ulnar deviation at the wrist, and the metacarpophalangeal joint is characteristic of rheumatoid arthritis. We look for muscle wasting or atrophy, and pay attention to the dorsum of the first web space between the metacarpal bones. We look for skin changes such as redness or scars, which may be related to previous corrective surgery, and thinning and bruising, which may indicate complications of long-term steroid therapy. We check out the nails for pitting and onycholysis. This is seen in psoriasis. And then we also check the joints for symmetry. On completion of the examination from the dorsum, have the patient turn the hand palms up and examine the palmar surface. Note any difficulty with this maneuver. We'll be looking for things such as the position of the fingers, muscle atrophy or wasting, things like thenar eminence only, possible carpal tunnel syndrome, hypothenar eminence could indicate ulnar nerve lesion, etc. We look for contractures. We look for deformities such as clawing of the fingers. Claw deformity is usually due to ulnar nerve palsy at the wrist. We look at the skin for palmar erythema or scars. And then we feel. With the palms up, we feel for tenderness along the flexor tendon sheets, which may indicate infection, and at the joints may indicate an inflammatory process such as synovitis. We check for warmth. This may indicate an inflammatory process. We compare with that of the wrist and forearms. We check for tendon thickening and nodules. We check for muscle bulk, especially in the thenar and hypothenar eminences. We also check the joints, which are best palpated on the posterior surface. We have the patient turn the hands down again. and you check for all of the joints of the fingers. We also check for warmth, tenderness of the joints, and then we now palpate the individual joints. Remember, bimanual palpation with the thumbs and the index finger in the wrists, and the thumbs are placed over the dorsum and index fingers are placed over the volar aspects. At the MCP joints, the thumbs are actually placed on either side of the joints and the index fingers in the palm underneath. At the interphalangeal joints, the index finger and the thumb of the same hand is placed on the sides of the joints. We also check for swellings. And if we do find a swelling, if it's bony, we think of about a Heredina Bouchard's. If it's soft tissue, we consider synovitis. And whether or not it's superficial or deep will be important to note. We will then do the motion of the wrist. For this one, we will ask the patient to do flexion. Ask the patient to place the forearm in a pronation and flexion at the elbow, and rest a flexed elbow on a bed or table. The patient is then asked to bend his wrist as far downwards towards the floor as possible. This is full flexion. We'll then return the wrist to the neutral position, and then with the forearm in a pronation and flexed elbow resting on the bed or table, ask the patient to bend the wrist backwards towards the body as far as possible. This movement tests extension at the wrist. Then we will do abduction and adduction. With the wrist in a neutral position, the forearm is supinated and held against the trunk. We'll ask the patient to bend the hand towards the ulnar side. This is adduction. Then we turn the wrist to the neutral position and ask the patient to move the wrist towards the radial side, which will be abduction. Remember, for all these movements, it's always easiest to demonstrate to the patient what you want them to do. We'll then continue with a special test for carpal tunnel syndrome. First will be the phalanx test. We'll support the patient's wrist with one hand by placing the thumb over the dorsum of the distal forearm and fingers over the volar aspect of the distal forearm. With the other hand, apply forceful pressure to the dorsum of the patient's hand to achieve extreme flexion at the patient's wrist for about 60 seconds. Radiating pain or paresthesia in the distribution of the median nerve is a positive phalanx test. We'll repeat it for the other side. Then the Tunnel's test is as follows. Percuss over the anterior surface of the wrist at the level of the most distal skin crease, just lateral to the palmaris longus tendon. The pain on the paresthesia in the distribution of the median nerve with this maneuver is a positive Tunnel's test, and it will be repeated on the other side. We will then do the thumb active range of motion. The range of motion of the thumb includes flexion, extension, abduction, and adduction and opposition. Move the thumb towards the index finger. This is adduction. And then away from the index finger at right angles to the palm, which is adduction. In flexion, the metacarpophalangeal and interphalangeal joints of the thumb is flexed. The thumb will now lie across the second and third metacarpal area. The thumb will now lie across the second and third metacarpal area. We'll then move the thumb in the opposite direction to demonstrate extension. To demonstrate opposition, bring the tip of the thumb in contact with the palmar surface of the fifth digit. Good. We then proceed with active range of motion. The motion at the finger joints includes flexion, extension, abduction, and adduction. Test all digits together by having the patient make a fist. Then test each finger individually for active and passive range of movement at the distal and proximal interphalangeal joints and the metacarpophalangeal joints. The distal interphalangeal joints, you immobilize the proximal interphalangeal joint by grasping the joint and middle phalanx between the thumb and index finger. Ask the patient to move the distal interphalangeal joints forward and backwards, which is flexion and extension. And for the proximal one, we use a hand not being tested. The patient pushes the finger of the other hand, except the finger is being tested, into hyperextension at the metacarpophalangeal joint and extension of the interphalangeal joints. Ask the patient to bend the proximal interphalangeal joint of the finger being tested forwards and backwards, which is flexion and extensions. You then do the same for the other fingers. A At the metacarpophalangeal joint, extend the fingers and flex the distal and middle interphalangeal joints. This movement places the fingertips and the palms close to the metacarpophalangeal joints, and the metacarpophalangeal joint will be partially flexed. Now flex the metacarpophalangeal joints fully by rolling the flexed fingers proximally. The fingertips now lie at the mid-palm level and the metacarpophalangeal joints are fully flexed. We then do abduction and adduction of the fingers, which occurs at the metacarpophalangeal joints. The dorsal interosseous muscles abduct and the palmar interosseous muscles adduct. This completes the movements of the hands and the upper extremities. We'll first start in the lower extremities with the examination of the hip. This examination should be done from a standing and recumbent position. Ideally, the lower limbs should be fully exposed from toes to the levels just above the buttocks posteriorly and the inguinal area anteriorly. The hip joint is located in the groin, so this will not be exposed in the lab. Only underclothes should be worn for this examination. We'll first look with the patient in the standing position to see if he or she can. And then we'll start to look for muscle wasting. Pay special attention for the gluteal muscles, the pelvic tilt, and the position of the lower gluteal fold. And with the patient lying on a couch face up, we will look at the hip for size and for scars. We will be checking for symmetry as well. And we will be checking for the circumferential and longitudinal dimensions. And we'll be looking at the skin for any changes such as erythema over the joints, which may be indicative of an inflammatory process. We'll check the length of the legs. And if there's an appearance of differences in length, an actual measurement will be taken on both sides. If not, then we can just estimate. Measure for the anterior superior iliac spine to the medial malleolus of the ankle on the same side with the limb straight, extended at the hip, knee, and the ankle in the neutral position. Again, if we notice that there is disparity. Deformities such as a fixed flexion contracture or an abnormal posture can be noted during this examination. We'll then proceed with feeling. We'll feel for warmth over the lateral hip and surrounded areas. We'll check for tenderness, which is over the greater trochanter. And then we will proceed with movements. The movements of the hip are flexion, extension, abduction, and adduction, internal and external rotation, and this is best done with the patient in a standing position initially, or it can also be done in a recumbent position. Added extension from the straight position is therefore in hyperextension. Active movement at the hip joint can be tested in lying and standing position as mentioned. Passive range of movement is done in a lying position. Each hip is tested separately with the patient lying on his back with and knees flexed. So we'll do flexion with the knee in 90 degrees and ask the patient to bring one knee as close to the abdominal wall as possible. Then extension, we return of the thigh from the flexed position to the straight position is extension at the hip joint. To test for hyperextension, have the patient lie on the side and move the upper straight lower limb as far posteriorly as possible. And that will be hyperextension. Then we will proceed now with abduction and adduction with the hip and knee at 90 degrees of flexion. We will do abduction, which can be tested by spreading the hips apart, and adduction by bringing them back together. There will be internal and external rotation. Okay, so for internal and external rotation with the knee and hip flexed at 90 degrees, have the patient rotate the hip inwards by pointing the knee in the direction of the other hip. This is internal rotation. To perform external rotation, point the knee away from the midline. The alternative methods are outlined in the lab. Only one needs to be demonstrated in an exam. There's a circular rotation while standing on one limb. and the other limb straight and free, the hip can be moved in a circular manner by combination of all the above movements. And then the same is done to the other limb. So we will then continue now with the special test for abnormalities of the hip joint. This is done with the patient in lying position. We'll first start with the test for fixed flexure contracture. This is called a Thomas test. We'll have the patient lie flat on his or her back with both legs straight. Place your hand under the patient's lower back to access full lumbar lordosis. Ask the patient to fully flex the right knee. You will then fully flex the right hip by pressing the right thigh firmly against the anterior abdominal wall. The lumbar lordosis is eliminated when the patient flexes the hip and the knee. This maneuver assesses the left hip. If there is a fixed contraction in the left hip, this procedure will result in flexion at the knee, with the knee losing contact with the couch or bed, and that would be a positive Thomas test. This is then repeated by flexing the left hip. We will then proceed with the examination of the knee joint. Examination can be done with the patient lying or standing, and always you should compare one knee with the next during the entire examination. So we will first look with the patient lying on the bed with the lower extremities straight and the examiner standing on the foot of the bed. We will observe for size. This can be changed often due to swelling. Swelling, as we mentioned, can be localized or generalized. It can be involving bony or soft tissue. In a knee with significant knee effusion, swelling may be seen in the popliteal area, and this is better observed with the patient in a standing position or on their sides, as demonstrated here. Good. We will then continue looking for things such as scars, symmetry, alignment. Remember, in alignment, we have to check for varus and valgus deviation. We check for posture. Valgus is a lateral deviation of the leg or knock knee, or varus, which is a medial deviation of the leg or bow legged. And varus and valgus deformities are often better observed with the patient, again, in a standing position. But again, if the patient is immobilized, you can observe it in the lying position. We check for deformity and muscle wasting, and we check the skin, again, for erythema, or a rash of psoriasis, or which is often seen as the extensor surface of the knee. We will then proceed with feel. We'll feel for temperature, comparing both lower legs with the other knee. Tenderness. With the knee extended, we'll palpate along the borders of the patella. With the knee, and then with the knee flexed to 90 degrees, we'll palpate along the joint line for the femoral condyles to the tibial plateau, all the way down to the tibial plateau. And then we check for swelling and be sure to palpate behind the knee for evidence of effusion or a Baker's cyst. A pulsatile swelling in this area will be a popliteal aneurysm. We'll then proceed with move. The movements of the knee are flexion and extension only. The patient should be fully relaxed to avoid voluntary resistance. The examiner can test flexion and extension with the patient lying on his right side, starting with the uppermost limb, left, straight. Have the patient bend his knee as much as possible. This is a full active flexion. Return of the knee to the jointed straight position is full extension. This is then repeated with the patient now lying on their left side. First with flexion, then extension. And then we will do the passage range of movement, which can be performed by the examiner by placing one hand over the knee and the other hand moving the leg backwards and forwards. Remember, we're feeling for crepitus, so we'll be palpating for crepitus during the active and passive range of movement. If a fracture is suspected, we do not check for crepitus. We'll then proceed with the special test of the knee joint. We'll first do the test for joint effusion. The first one is called the bulges sign. We apply an anterior compression to the lower third of the patient's thigh with the left hand, thumb on one side and the finger on the other side. While maintaining the pressure, we slide the hand down to the upper border of the patella. This maneuver empties the suprapatellar pouch of fluid. We maintain the pressure and we stroke the medial side of the knee upwards, thus emptying the medial compartment, and next we stroke the lateral side downwards. If there is an effusion, the medial compartment will refill with fluid and a bulge will be noticed medially. This, of course, will be repeated. We then proceed with the second test, which is called the Ballotman sign or the patella tap. We empty the suprapatellar pouch as above. The fluid in the knee will now be forced behind the patella. With the index and middle finger of the right hand, we push the patella gently backwards. If there is an excess fluid present, the patella will initially be ballotable. Continued pushing will result in the patella colliding with the femoral condyles, and a bounce will be felt, or what we call a palpable tap. We'll then proceed with the test for the ligament integrity. The ligaments of the knee joints are very strong structures, can readily withstand a force greater than 3 times the person's body weight. This means that to test the integrity of these ligaments properly, substantial force has to be applied. We'll first start with the medial ligament. With the knee flexed at 15 degrees, we'll stress the medial side of the joint by placing one hand on the lateral side of the joint and holding the lower leg with the other hand. We apply an inward pressure to the lateral knee, which is a valgus stress, and we pull the lower leg outwards laterally. This is referred to as a push and pull. Excess movement, pain, or both on medial side of the knee with this maneuver indicates damage to the medial collateral ligament. We will then do the lateral ligament with the knee semi-flexed at 15 degrees. We stress the lateral side of the joint. Place one hand on the medial side of the joint and hold the lower leg with the other hand. Apply outward pressure towards the medial knee, which is the varus stress, and pull the lower leg inwards, which is medially. This is again a push and pull. Excess movement or pain both in lateral knees with this maneuver indicates lateral collateral ligament injury. We'll continue with the anterior cruciate ligament, which is also called the anterior draw sign. We flex the knee up to 90 degrees with the foot flat on the couch. We sit on the dorsum of the foot to stabilize the tibia, and we place both hands around the upper tibia with the thumbs resting on the tibial tuberosity and the index fingers on the hamstrings and tendons. We forcibly pull the tibia towards. There is a small degree of motion in the normal knee. Excess movement, however, which is usually painful with this maneuver, indicates anterior cruciate ligament tear. We'll then do the posterior cruciate ligament or the posterior draw sign. Before the testing, look at the knee from the side. This may indicate a step back of the tibia and is referred to as a posterior sag. Now with the knee again flexed and stabilized, the examiner, hands as above, forcibly push the tibia backwards. Excessive movement will usually indicate posterior cruciate ligament tear or, of course, tenderness. We'll then proceed with the test for the cartilages. So if there are cartilaginous medial and lateral menisci injury, we will first start with the McMurray's test. For the medial meniscus, the patient is supine with hip flex and knee fully flexed. The examiner holds the knee to be tested with his left hand. With the tip of the thumb and index finger on the medial and lateral side of the joint, with the right hand, grip the instep and sole of the patient's foot. Externally rotate the leg and then slowly extend it while placing a varus stress on the proximal hand over the medial joint. As the knee is straightened, you may feel a click and the patient may experience pain or clicking on the medial side of the knee, suggestive of a medial meniscus tear. In a severe tear of meniscus, a fragment of meniscus may become trapped between the tibia and the femur, locking the knee and preventing full extension. Alternative techniques, of course, are discussed in the manual. For the lateral meniscus, we carry out the same above maneuver, but now we rotate the foot and the leg medially, which is now internal rotation, gradually straighten the knee joint and applying a valgus stress to the lateral knee. A click or pain experienced by the patient on the lateral side is highly suggestive of a lateral meniscus tear. In a severe tear as before, a fragment can be caught, and this will actually lock the knee and prevent full extension. We do the same examination on the other knee. We'll then proceed quickly with the examination of the ankle and foot. Look at the footwear for any abnormal or asymmetrical wearing of the sole. Always compare one side with the next. We'll first start with the maneuver of looking. The patient should be asked to sit on a couch. First, we will start by looking. The patient should be asked to sit on a couch and the lower extremity should be flexed at the knee with the leg hanging over the edge. We check first the skin for rash of psoriasis, the nails of the toes for evidence of psoriasis, which is usually pitting or onycholysis, erythema indicating inflammation, callus formation over the dorsum and plantar surfaces, and ecchymosis indicating possibility of trauma. We'll also be checking for swellings, for alignment or deformity of the forefoot or toes. Remember things such as hallux valgus of the great toe at the MTP, and clawing of the toes. Symmetry shall be checked for next with the patient's weight bearing. And then we will check for alignment or deformity of the hindfoot, the ankle and the subtalar region, looking from front and looking from behind, the arch and the midfoot, look from the side to see dropped arch. This may be present in an otherwise normal individual. We have the patient stand on his or her toes. In the presence of a pathology, a normal arch will be observed. We also check for swellings and thickening of the Achilles tendon. For this, we have to look from behind. We then proceed with feeling. For this, we can ask the patient to sit again. We will be feeling for warmth, as before, with the back of our hands. We'll be checking for tenderness. We palpate for tenderness over the dorsum of the interphalangeal joints, the forefoot, tarsal joints, subtalar, talonoclavicular, and calcaneotalar joints, and over the anterior and lateral ankle joint. We gently squeeze across the MP joints using the technique outlined for MP joints of the digits of the hand. And lastly, we check for swellings. We feel for swellings. For the movement of the foot, we will first do both active and passive range of movement. Generally, the motion of the digits of the foot is tested only in the big toe, as it is difficult to independently test motion at the other toes. We will first start with dorsiflexion and plantar flexion of the ankle, which is the tibio-talar joint. We ask the patient to move the entire foot towards his trunk, which is dorsiflexion, and then move the entire foot downwards, allowing the toes to point to the floor. Inversion and eversion of the subtalar joints. We ask the patient to twist the feet towards the median plane, allowing the sole of the feet to face each other. This is inversion and abduction. And then we ask the patient to twist the feet outwards, allowing the sole of the feet to face away from each other, which is away from the medial plane. This motion represents eversion and abduction. We will then continue with abduction and adduction, which is at the subtalar joints. With the patient sitting on the chair, the foot lightly resting on the floor, have the patient move the foot away from the midline along the floor. That's abduction. Then have the patient move the foot towards the median plane along the floor, which is adduction. General abduction and eversion are coupled, and so is inversion and adduction. Inversion and eversion at the mid-tarsal or transverse tarsal joints. We hold the heel of the patient's foot with one hand, preventing motion at the subtalar joints, and passively invert and evert the foot. Do the same for the other extremity. And then dorsiflexion and flexion of the big toe. We ask the patient to bend the big toe towards the floor, plantar flexion. Then bend the toe upwards towards the trunk, which is dorsiflexion. We then please note that there's an active range of motion of the big toe, and the MP and interphalangeal joints generally move together. In terms of function, testing for the function of the lower extremities involves analyzing the gait, which was already done. This concludes the examination of the musculoskeletal system.